Hello, my name is Joe Hiller, and for my EMS documentation class, I am doing MCI Triage Communication Styles. And I am doing it none other than here in my hometown fire department in St. Paul. So, a little bit about me. I am an EMT, I'm a volunteer for St. Paul, and I'm going to be working for Woodburn Ambulance here in a couple of days. And also, I am going into the paramedic program, and I am doing this class to get my prerequisites done. So a little bit about my history and past experiences with MCI and triage is that since being a newly certified EMT, I know about red tags, green tags, yellow tags, and black, and just making sure that when we approach the scene, we tag them or we label them as deceased or green or yellow or red. Red being the most important care, and also paying attention to respirations, pulse, ammentation, RPM is the better way to understand it. And we do this in training at St. Paul, and this is a big part of our training to understand, like when we enter MCI or mass casualty incident, that we need to identify which patient priority is more important, and that we get good communication with the physician of bringing in the patient that is more important to understand. So I'll be having a guest speaker in here with me. I'll have Assistant Chief and Paramedic Daniel Mullen. A little bit about Daniel's history is that he has worked at Woodburn Ambulance, and he earned his paramedic certification a while back, and he helps out with the training here in St. Paul and medically and on the fire side as well. And I'll be having him here speak with me about the communication style and the training, and reviewing most of the calls that we've had in the past year or a couple years back, and how we've improved as a fire department, specifically for St. Paul. I won't be getting much into other departments. I'll be focusing more on St. Paul Fire Department and how a group of farmers train for mass casualty incident, how the medics at St. Paul also are training to make MCI quick and efficient, and also to identify the priority of the call. And I'll be getting into it soon, and here is the man himself, Daniel Mullen.
Morning.
Morning. All right, Daniel. So I just basically touched a little bit on your background. So I know you're assistant chief here, and you're a main medic, and you help out with medical direction, do the training here, and you just want to touch a little bit more base on more of your background, just to like tell them more about like what experience you've had. And this is more than MCI triage. Like, we can talk about how medical calls have been improving over the years, but just a little bit more touch. You worked at Woodburn Ambulance?
Yeah, and I actually started in Corvallis Fire also.
Corvallis Fire.
In 2001, and was a resident volunteer there, and worked on an ambulance every third day.
Every third day.
Yeah, and by doing the resident volunteer program, you got to live for free, per se, but you had to work on the ambulance.
Yeah.
And then I went to Oregon State at the same time and got my bachelor's degree, and simultaneously did all my paramedic back course at the same time. Yeah. And then went from there to Woodburn Ambulance, and throughout the whole time I was with St. Paul the whole time as well.
Okay.
So it's June of 2001.
All right. And during that time of Woodburn Ambulance, how many mass casualty incidents have you encountered? And when you were on those calls, what type of communication style did you use?
So it's kind of a loaded question. I've actually had more mass casualties with St. Paul than when I was in my tenure with Woodburn Ambulance. So regardless, it's your foundation, Joe, every time. You stick to your ICS and from your NIMS training, and you come back to your incident command structure and you prevent the freelancing as best as possible of your responders. And so if you give clear communication and direction, it will make a very chaotic scene run very smooth as possible. And, well, you know, Dr. Heiser, our physician advisor, he actually is kind of taking the forefront on this mass casualty, active shooter, bombing responses, and he gave a 2-hour presentation at the Newport EMS conference here in 2019. And St. Paul, because we've had about 5 or 6 in the last 18 months, all of those he critically debriefed them with his whole audience and how he's taking us and moving to that. So instead of necessarily calling it triaging, but sorting. So we sort, we have our casualty collection point, and we move through and we get those patients, they need an operating room. They don't need us there. They need us to bandage them, try to make a life-saving procedure.
So it's just more about speed and like
efficiency and speed.
Like I've said earlier in the video, like we pay attention to respirations, pulse, and mentation. You know, if they're like for black, which is deceased, like if they're not breathing, if they have no pulse and they're not responding, basically, you know, we cross their legs and hold their arms up so that we know when we're on scene that they're dead and they're not a red, a green, or a yellow, right?
Exactly.
Yeah.
Did you touch on how we sort with the group yet?
Yeah, we'll get into training here in a little bit, but I've just basically briefed with them that, like, you know, there's red, green, and yellow, and black, but we'll get into deeper detail, and we'll get into like how we train and like how, you know, how training for triage can be more efficient at, and how we train here at St. Paul Fire.
Sure.
Yeah. But a little bit on Dr. Heiser's part, like I want to go more into clinical settings. So like when you know Dr. Heiser, and then when you're transporting the patient, whether it's red or yellow, what are you telling Dr. Heiser when you're transporting that red patient? Because you said earlier in the video that we need to get that patient into the operating room right away.
Right, so that is, that's gonna start with your clear communication. That comes from your sorting team to your casualty collection point to your transportation person. Your transportation person will have a list of area hospitals and how many criticals and non-criticals they can take. And so hypothetically, say we had a mutual aid ambulance coming from the south, like a Kaiser, whatever. Send them with a patient back to the south towards Salem. That's our nearest regional by ground facility that's got an operating room that's a level 2 trauma center. They're gonna take red ones that way. You're gonna fly red ones to north.
And with the assistance of life flight?
Yes. Absolutely. And you'll get every helicopter you can find coming, depending on the size of your incident, to get up and over all the traffic. And then, you know, if it's that bad of a scene, you're gonna take some really injured people to Newburgh. And then granted, it's not a trauma facility, but they're gonna help you get an airway and stop bleeding and get them to their next
And
spot.
we're talking more of our greens and yellows.
Yes, but in the event of an MCI, you gotta get to the nearest facility sometimes. Because they might not have, that patient might not have 45 minutes of drive time.
Okay.
You might have to go to Newburgh, get help. Because they can operate too. And that all comes back to transportation. Because when that transportation person clearly communicates to the receiving hospital, like, we have an MCI, and you're gonna be getting X number of patients, then they're gonna follow their own internal policies and protocols and standard operating guidelines of what can we do to prepare, and they do an all call, and they get, you know, however many resources they have available in and prepared, because they know they're gonna be getting, say, 5 reds from St. Paul that they normally would not get, but today they are because of the size of the incident.
Okay. Yeah, it's basically just about, just efficiency and just.
The transportation officer, that is a very critical role in the smoothness of the MCI. Because you got your 3 steps kind of.
Yeah.
And to circle back, after we sort the initial triage and we go to the casualty collection point, if you're waiting for ambulances at that point, that's when you create your treatment centers. And your triage can be more formal at that point if you're going to use tags or how you're going to keep track of the people while they're waiting. But you don't want to ever have someone bleed out because you're waiting for the tag. If you know they're a red, they need to get on the road and going if you have the resources available to get them out.
And we're also paying attention to compensated shock, decompensated shock, and making sure they don't go in that irreversible shock as well.
When you get enough people on scene, absolutely. Some of that stuff, you're going to do, and this is where Dr. Heiser would be a great person to run this by too. He has a lot of data from the West Virginia shooting that there was, I believe it was 37 total. And out of those, only 11 people had to be transported. And out of those, I think it was only 3 needed a critical intervention.
Okay.
They all just needed to get to the hospital ultimately. But 3 needed some level of intervention, whether it was a tourniquet to save a life, or an advanced airway, or a dart in the chest to decompress the pneumo.
I also wanted to touch base on that, also communicating with law enforcement. So let's say we either have, a shooter and it turns into an MCI, what is law enforcement's what is law enforcement's role as far, we know that they keep the scene safe, but are they helping, they're also helping us, right? Pack patients,
You're
and,
gonna
hold bleeding.
So back to our NIMS training and that strong ICS, unified command. So that means in the command post, and the command post isn't going to be on top of Joe's scene here. The command post is going to be off so that they don't get caught up in the weeds. And you're going to have every agency that's got a role in that command post with their highest ranking officer or whatever their designated person is that's their duty officer of the day. So, law enforcement, fire, and here we're kind of unique because we're fire and EMS. So that's one person for us. Some sort of a public works, state police. If it's at the rodeo, the city, the rodeo. You're going to have 7 people in a unified command so that all these pieces are working together. And from that, with law enforcement, specifically with us, they're going to be protecting us with long guns because that scene is not secured, but it's safe enough to save a life. And so they will be set up, whether it's by perimeter or they go in with us with a gun. It just depends on whatever your incident is. And back to packing patients, you're going to use anyone who's able-bodied to help you. So even if that's a layperson that's in the crowd that says, I'm CPR first aid trained, can I help? Put them with an EMT or whatever and have them help pack patients. That's a great utilization of resources because as you know, we are pretty rural, even though we have metro so close to us. It still takes 20 to 30 minutes to get more resources here. So you got to utilize what you can at the time.
And and I'm just gonna jump into as far as as training here in St. Paul and just explaining to them how we train here in St. Paul, making sure we discuss communication style, go over the 3 colors of triage and what we're paying attention to. And I've touched base on this, but for any of you that don't know, so green means walking wounded, yellow means they're okay but they have minor injuries, red is serious and they need care immediately, black is deceased, and also paying attention to respirations, pulse, and mentations. But also I've done drills here, but going deeper into that, as an assistant chief, what are you paying attention to when we're all training? What are you looking for as an assistant chief and like when we practice MCI? Because, you know, training is as serious as in the field.
Sure, you're only as good as you train.
Yeah.
And so we always want to have clean, concise training and that everyone's on the same page. And so as we're working towards the TCCC style of training that we are doing with MCIs, what we're looking for is like, just as Dr. Heiser has painted it to us year and year in the last, we've been doing it for 3.5 years now. We walk into the room, anyone who can walk, go over to this tree, put a firefighter with them. Can you hear me? Show me 2 fingers. Okay, all those people that are laying down that can't walk but have 2 fingers up, those are your yellows. So you've got your green and yellows done. Hold your hand up with your 2 fingers. Everyone who's down, they're either a red or a black. And at that point, you either put them in that universal symbol you discussed, crossing their legs, arms above their head, or black survey tape works also that we carry on our trauma kit. Or they're a red, and that's where you do your RPM.
Yeah.
Or MARCH is another mnemonic, massive hemorrhage control, airway, respiration, circulation, or hypothermia.
Okay, so that's March.
MARCH, and MARCH is very excellent because you can do it in under a minute, so you're not getting caught there with that patient, but you might be able to put an MPA in, and you gave them an airway enough that they can live until they can get a definitive airway when they go to the casualty collection point.
Yeah.
Or you're putting on a tourniquet to stop a massive femoral bleed that would kill them also. Hypothermia, we're not going to see that as much, I guess, in the dead of the winter, but that's more or less from all their blood loss, you know, that they're going to get chilly. But
yeah, just like paying attention to the extremities, seeing if they're pale, cool, and
sure,
diaphoretic.
We just don't want to get caught on that patient for too long, and that's all part of that speed, efficiency, and effectively getting through those people that you got to get in under a minute. You got to do all this on them and get to the next one.
Yeah.
And that's when we utilize the law enforcement, the layperson, the firefighters. Okay, this person needs to go next, get them over to the casualty collection point, and that's where your transportation officer is there. Okay, I've got a John Doe, because you might not get their documentation, who's about 25 years old with this injury. They're going to Salem Hospital by this ambulance. Boom, they go, give them a green 2, you just got rid of 2 patients.
Daniel, I want to thank you for coming here and talking to me about MCI and communication style. Anything you want to tell, you know, just the audience about, you know, future MCI or any recommendations for communication style? Just any?
Just follow your incident command setting and structure, and refer back to your training, because if you can, it's going to be a chaotic scene, something you've never seen before. And we've had a lot of MCIs in our district here in the last couple of years, and they've all been motor vehicle crash related. But because we've been doing this training, we've saved a couple folks just by doing an advanced airway procedure, and that all came back to our training. We had an EMT basic that held 2 airways open in a car crash, and it gave them a chance. The people ultimately did pass away, but it gave them a chance to either be an organ donor or their family to come tell them goodbye. And that, to me, is still something at the end of the day that we can be proud of, that we gave that person an opportunity to possibly live.
Yeah. Well, I just want to thank you again.
Thank you.
All right.
Best of luck.
And that'll be it for my communications project with MCI. And I just want to, again, thank Daniel. I want to thank everyone else that has helped me with my project. I want to thank my wife Shelby for helping me out with videography and editing with this. And this was a great class. I loved it. Thank you.